Good evening, and greetings to you from Saginaw Valley State University. My name is Heidi Lang, and I serve as the Pre-Health Professions Advisor, raising up the next generation of healthcare providers. The Your Health Lecture Series is brought to you through the Early Assurance Program partnership that SVSU has with Michigan State University College of Human Medicine, and is also sponsored by My Michigan Health, the Midland campus. We welcome our in-person audience and also all of those of you joining us on Zoom. Our presenter this evening, Dr. Chioma Torres, earned her doctorate of medicine from Michigan State University's College of Human Medicine. Following that, she completed her residency at Phoenix Children's Hospital in Phoenix, Arizona. Her commitment to further specialization led her to a fellowship in pediatrics developmental behavioral at the University of Michigan, and she continues as a consultant to their fellowship and resident education programs. Board certified in pediatrics, Dr. Torres has a keen focus on various clinical interests, including adverse childhood experiences and childhood trauma, infant mental health, media's impact on child behavior, the intersectionality of neurodevelopmental disorders with race, ethnicity, socioeconomic status, and gender, and addressing health disparities. She serves as Division Chief of MSU CHM Development and Behavioral Pediatrics Division, and if that's not enough, she's also the medical director of the Developmental and Behavioral Pediatrics Clinic. She's an incredibly busy woman. We are grateful that she's here with us this evening. So please join me in welcoming Dr. Torres to SVSU for this public lecture titled Autism Diagnosis and Interventions.
Can everyone hear me okay? Thank you so much for inviting me here. It's really been nice to hear about the partnership and see the campus and learn more about this program that has been going on. I was asked to come and talk to you about autism, but it's actually not my area of research. The interest that she listed is my area of research. So what I'm going to talk to you about is, I guess we can start on this slide. It may not be working though now. But what I'm going to be talking to you about is what I see clinically, basically what I do. And at this point, you probably know someone who has autism. And so I'm hoping your takeaways will be learning a little bit more about this experience and what their lives are like, and interventions that are available for them. So here's my objectives: to understand the diagnostic criteria, but also the challenges. This is not always easy to diagnose autism, and some of the evidence-based interventions, the importance of a team approach. There's other coexisting conditions that I want you to learn about, and then also school supports and accommodations. So I was asked at one of my other talks about the prevalence in the world, and so I added this here because it is a good question. So you can see it's different in many different countries. I don't know, it's pretty big up there. But the WHO in 2021 estimated that the world prevalence is about 1 in 127. But you can see some countries have a higher prevalence at the bottom, and we're right there, Japan and South Korea. I will say that many countries have stigma about autism, and if you don't see these children and you don't count them, then you won't know what the prevalence is, and it's probably much higher. So in the US right now, our prevalence is 1 in 31 children. And the reason why it's children aged 8 is how we collect that data. So it's through the Autism and Developmental Disability Monitoring Network. So that is 16 different sites and 14 states who are gathering their data of how many children are getting diagnosed. And so that's how we get that information. Boys are still diagnosed more than girls, but that number is shrinking. It's about 3 to 1. And autism is reported in all racial, ethnic groups and socioeconomic status. We do not know the etiology of autism, but we have some information that I'm going to share with you. It's multifactorial, is what we know. And there is a strong genetic component. So for monozygotic twin studies, there's a 60% concordance rates. For Fragile X, we know that is the leading cause of a single gene mutation for autism. Everything else is going to be an association. So these are conditions that we know increase your risk of autism, but they're not the cause of autism. And I'm going to list a few of them. Prematurity or low birth weight, that's under 2,500 grams, it increases the risk of autism. So those NICU follow-up clinics, that's what we do end up talking about in some cases. There is an inverse relationship with that. So the lower the gestational age that they're born at, the higher the risk of autism. Older maternal age and paternal age is associated as well. And IVF, but not directly, is the confounders of having these older age. When you tend to go to IVF, you're at higher risk of multiple births and higher risk for preterm births. The birth order seems to matter. And if you have one child who has autism, the next child or subsequent children have a higher risk. There are certain environmental exposures or prenatal medications. Valproic acid is one. Maternal health issues can increase your risk. So diabetes, hypertension, obesity, or CMV while you're pregnant. And then mental health conditions like schizophrenia increase your risk. What is not listed on here is the MMR vaccine, because that is not associated with an increased risk of autism. So this is the demographics we have now. This is from 2023. And you can see that right now, Black, Latino, Asian, Pacific Islander are getting diagnosed more than white. And so 2018 was the first time that there were the equal number of Black and white children who were diagnosed with autism. Prior to that, this was largely a white boy condition. And so this change in demographics is really startling. Hopefully it's not the pendulum swinging all the way to the other side, but we're more aware of what I'm going to talk about in a little bit, the biases that we may have in this diagnosis, and we're catching more of these. So this is a table showing a study about the odds of receiving another diagnosis prior to the diagnosis of autism. And it's an older study, but it shows the trends of what was happening before that 2018 time when Black and white boys and girls were diagnosed equally. So you can see that the odds of having another diagnosis before autism was 2.6 for Black. And then the other startling thing in this chart is Medicaid eligible. If they were Medicaid eligible greater than 1 year, their odds were 3. And this is compared to Medicaid eligible less than 1 year. So that affected who was their diagnosis of getting autism on time. These were children that ended up getting a diagnosis of autism later. So this is basically information about what happened before this 2018 change, where you can see the demographics changing. But prior to that, Black African-American children were getting diagnosed about 1.5 years later than white children. Latinos about a year later. Girls on average about age 6. Children with lower socioeconomic status or having speaking other languages, they experienced more barriers and had a later diagnosis. And what seemed to be a protective factor is higher education for your parents. That was associated with an earlier diagnosis. So I'm going to talk about testing. I was trained in the ADOS and some others. The ADOS, I'm going to use their abbreviations, but the ADOS is, sorry, I'm echoing now, Autism Diagnostic Observation Schedule. The gold standard right now is ADOS and the ADIR, which is an interview. You actually, for the ADIR, don't even need to have the child present. It's just an interview with the caretaker. And so we all use different tools. The insurance, actually, it dictated whether you had to go to this autism evaluation center or not. And now that's kind of going away with Blue Cross Blue Shield. And so the teams are going to change, I think, over time. But the specialists involved in these teams could be neurology, neuropsychology, psychology, psychiatry, developmental peds, general peds, and speech and language pathology. So the teams vary with who's going to be doing them, and also what tests they use. They may use their own discipline-specific testing along with one of the autism testing. So if for developmental peds, if we're going to have a multidisciplinary team, we typically will work with a speech language pathologist, because we want to make sure that there is a social communication deficit. The ADOS is really a lot of opportunities for play, to see social interaction with the child. And so sometimes the ADOS is borderline. And so having that other input from someone else can be really helpful. So I will say that you can have a high score on an ADOS and still not meet the criteria for DSM. And so other conditions that can cause a high score for an ADOS could be trauma or severe anxiety, and they're not going to engage with you because they're so anxious, or selective mutism. And so after I do the ADOS, whether it's high or not, I then go to the DSM criteria and see if they meet criteria. And so this is called the A criteria. And the A criteria is deficits in social communication. And you have to meet all of these. So the first one, social emotional reciprocity. So that's the give and take. When they're younger, this could be playing games like peekaboo or playing ball, but something that's reciprocal. As you get older, this could be in verbal. This could be back and forth conversation. The next one is nonverbal communicative behaviors. So this is gestures, eye contact, facial expressions. And then the last one is deficits in developing and maintaining relationships. This can be tricky with the diagnosis because a child can have some challenges in these areas, and then you have to decide, is this a deficit? Because autism is a disability. And so if they have some challenges, that may not still meet criteria as a deficit. But you have to have all three of those. And then this is the B criteria, and you only need 2 of these. The first one is stereotype repetitive motor movements. So this could be hand flapping, toe walking, lining up of toys, pacing, repetitive phrases, echolalia. The next one is insistence of sameness. So needing to have the same routine, needing to eat the same thing every day. The next one is a highly restricted fixated interest. And this one is tricky actually for some kids because I don't know if any of you know about K-pop Demon Hunters. But right now they're very popular. And kids are going crazy for them. And so this is a highly restricted fixated interest, but is it out of proportion? And it can get tricky. It's easier when it is more atypical of a highly restrictive interest. So for example, my son, probably when he was 6, really started liking flags. So he learned all the different flags in every country and all their capitals. And so that's a little easier to pick out. And then hypo or hypersensitivity to input, to sensory input, and you only need 2 of these. Once you get the diagnosis, then you can go to the severity of symptoms. And so you can see there's level 1 to level 3. Level 1 requires support, and level 3, very substantial support. This can be helpful for prognosis, but it actually isn't something that I focus on a lot with families. Families usually want to know what it is, though. But children can really move up and down on this scale, and so it doesn't really weigh a lot at the time of diagnosis. As the time goes on, it can change. So after this, for many people, that's the end. Now you get connected with the interventions. And I will say that when I connect families to interventions, it's not to become a neurotypical child. My goal for them is to develop skills in whatever area that they have challenges in. And so for social communication challenges, or if you want to get more play skills, you can see a speech and language pathologist, or go to play-based groups, or have social skills groups. If you're looking for help with cognitive rigidity, so this is that black and white thinking, things have to go one way or another, good or bad. Cognitive behavior therapy can be helpful. It also can be helpful with emotion dysregulation, or how do we cope when things aren't going our way. OT is probably my favorite, and I think anyone from Lansing will probably say I might refer a little bit too much. But they just are so wonderful at helping with play skills, sensory issues, identifying emotions, and also what tools can we use based on our sensory profile to regulate and cope better when we're in a situation that's uncomfortable. ABA can help with all of these as well, and we'll talk a little bit more about ABA. And then an IEP support. So IEPs are individualized education programs and through the school, and we'll talk a little bit about that too. Some of the things I think about when I see families back and why I want to see them back within about 6 months after diagnosis is access and to the interventions and how that's going for them. Because sometimes it's not as easy as we think of just connecting them. This article is from 2020, and it really describes some of the disparities we see with access to interventions. So what the study found is parent education, again, is protective. They were more likely to have access to an IEP, OT, ABA, or autism-specific services. Racial and ethnic minorities were less likely to have access to these. And Black and Latino children have this lag time from the time they are diagnosed to the time they actually get connected to interventions is longer for them. Black and Latino children with autism were also less likely to see a specialist, and I'll talk a little bit later about coexisting conditions, but to not be able to see, not seeing a GI or a neurologist is very alarming. It also found that they were less likely to have studies once seen by those specialists. So this would be like a sleep study or others. Black and Latino children also had lower use of specialty service procedures, as I mentioned. Latino children were less likely to receive an IEP, and then they were less likely to be in OT or speech compared to all other races. They were less likely to have autism-related services and respite care. Socioeconomic status also played a part. So children of low socioeconomic status were more likely to have, less likely to have a personal doctor. They were less likely to be enrolled in ABA or receive fewer hours of ABA or earlier care and this continuous care that we're looking for or other referrals. Oh, and so higher socioeconomic status was protective. Again, they were more likely to have their children enrolled in ABA and have OT. Rural areas also have disparities. So it makes sense. There's not going to maybe be a lot of access to specialists, and they may have to go to an urban center, but not only that, it's going to be ABA or other therapies may not be in those areas. And then quality of care. So this was more Black and Latino parents of children with autism who said they were given less information, they received less family-centered care, they felt their providers spent less time with them and were less sensitive to their concerns. So I'm going to talk a little bit more about the interventions, but that's why I want to follow with these families and make sure that they're getting into the things that they need to, and checking my own biases, because I'm the gatekeeper for these. So making sure I'm not being part of the problem with getting them into services. So ABA uses the ABC techniques. I'm going to talk a little bit about it because I figured maybe you guys didn't know a little bit about ABA. The ABCs are antecedent, behavior, and consequence. So the antecedent is what occurs before the behavior, then the behavior, and then the consequence is what happens after the behavior. So an example of this is, let's say a child is in school, they're given an assignment or a task to do, and they don't want to do the assignment. We don't know why they don't. It could be that the work is hard, they have a learning disability, it could be they just don't want to, many reasons. But their behavior then, because they don't want to do this, is that they throw things or they throw a chair or something like that. The consequence they have then is they get to escape. So rightfully so, to keep the other students safe, they're removed from the classroom and they get to escape the work that they didn't want to do. And so inadvertently, we're kind of reinforcing this type of behavior. So understanding the ABCs is really important. Another example will be an antecedent may be walking into the cafeteria and you have noise sensitivity. It's very loud. And so again, could have aggressive behavior. The consequence then is they get to be removed, go to a hallway or something and be more, and it's more quiet. But understanding that now, we can, maybe provide earbuds or maybe provide a quieter space for them to eat so we understand better and prevent some of these behaviors and discomfort too, not just the behaviors. ABA is meant to be intensive and long-term. That's what the studies have looked at. I have a few patients who are doing 40 hours a week, but usually it's less than that, and for many years. And you can basically tell by how long these hours are going to be that it's thousands of dollars. This is a very expensive intervention. And I think it was 2012. Sorry, I'm just checking my notes. I think it was 2012 when Michigan had any state regulated insurance has to provide autism related services. So there's still some insurances that don't, but you can imagine before 2012, many people did not have access to this intervention. What we learned from ABA research is that it helps children gain intellectual functioning, language, daily living skills, and social functioning. I'm going to talk about a few of them just so you get an idea of what it looks like. Discrete trial training is one of the oldest ones. It's also the most structured. You'll usually see a table, and they're breaking down the skills that they want the child to learn into small pieces. And then they're having them repeat this routine over and over again to earn a reward. I have really small videos. They're really short, just to kind of get an idea of what this looks like.
Are we working for Elsa again or fishy? Fishy, okay, let's work for the fish. Huh. Yay, you got the crab.
And actually, for time's sake, I want to actually move ahead because you saw the learn task, so learning what a cup is, also using her gesture and identifying and labeling, and then she got the reward. Another popular ABA technique is pivotal response treatment, and both of these, by the way, are evidence-based. This one's a little bit different. It uses more of what the child is into, what the child is doing already, and they're not sitting at a table to learn more skills. And so I'll have you watch just a little bit of this one.
Hi, Mary. Mary, hi. Here. We're gonna play with some toys today, okay? Look at all of these toys. What toy would you like to play with? Toy. Do you want to play with the puppets? Okay, nice job letting me know. What puppet would you like to play with? Okay, you want to play with the frog? Good job. What color is it? Green, it is green. Can you say green frog? Green frog. Nice job. Here you go.
All right, so I think you get the idea with that video too, of how it's different. Another really popular model is the Early Start Denver model. This one's typically for younger kids, so like 12 months to 48 months. It's using more naturalistic approach and at their developmental level. And so I'll show you a video of this one.
Yeah.
So with that, what she's doing, she's choosing a song that he enjoys really well, and then waiting for him, singing the song until stopping at a point so that he then learns how to initiate and say, I want to do this again, or I like this song. ABA has, so the board certified behavioral analyst is the one who either has a master's or a PhD. They're the ones who come up with the goals and the plan of care for the children, and then they supervise techs. Techs are actually the ones who are going to be coming into the home or working with the children one-on-one, like in the videos that you saw. But the training for the techs can be different, and sometimes the families can experience that. And so some training can be for the registered behavior therapist, that's like 40 hours. They do take an exam. And so they may be more experienced, whereas other behavior techs are not. And so that can be a challenge with ABA. Another issue might be continuity, because these techs have a high turnover rate. And so they may not be with the children as long as you can tell with routine, that might not be something the children can handle well. The next step is to decide in-home versus in-center ABA. Usually in Lansing, at least, I just tell families to get on all the lists, because it can take up to 6 months from the time they get diagnosed till the time they actually start ABA. And so I would just put my name on all the lists and see who comes first. Make sure you are in agreement with the goals and you view this facility and things like that. Otherwise, in-home versus in-center is, if they have more behaviors in one setting, maybe if it's more in the home, then that might be something you choose. Hours of therapy can be a problem. So some centers will say you have to have 15 hours a week, or you can't be in our center. And so if families only have 8 hours available, then that's something that they miss out on. And also access, there may not be an ABA center in your area. I do keep in mind when I talk to families about ABA that there are advocates who are against ABA. And this is for good reason. They were children, and now so these adults were children during the beginning of the ABA, and there were very traumatic experiences using electric shock and more. And so they are speaking out against those. They also have thoughts about having this repetition for the children, or how the long hours might be problematic. And so approaching the family where they are and in response to, because just because they get the diagnosis of autism doesn't mean they're going to want ABA. And the last is medical necessity. So this is one that, so some providers may say, yes, you have autism, but I don't think ABA is a good fit for you. And so they don't go on to recommend that. I typically will tell families, if they're interested, that they should go forward with ABA, because technically it's been proven to be helpful for all age groups. And if the BCBA and the techs are trained, they should be able to help children of low severity. They can work on conversation skills, and it doesn't have to just be a certain type of child that goes to these centers. There's other evidence-based interventions that children can go to. If you want to build skills with social skills, there's Peers is a manualized program that children can use. It's actually for teens and adults, and it's virtual, which is nice. So you can do this when you are in a rural area. The problem is that it does cost some money. And I guess I will say for social skills groups, these are also in ABA centers. They're in the schools, and so there's other ways of getting social skills groups, but it won't be this same manualized one. Learning skills of activities of daily living. So again, there's a manualized program that we know is evidence-based called Surviving and Thriving in the Real World. But if you don't have access to that, what again I like to do is send these kids to OT. So an example of activities of daily living, let's say teeth brushing. So maybe they're having sensory challenges with the teeth brushing, and so that's why. So understanding that more, the OT can help with. Also, there may be weakness in their hands, or learning how to do that turn. And so an OT can be really helpful with our buttons and getting dressed and many other ways. Getting speech and language skills. Again, a speech pathologist is going to be very helpful, but you can use other systems too. So there's the picture exchange communication system, there's augmentative and alternative communication device. I see a lot of kids who have extreme behaviors, and once they have a way of communicating, those behaviors go away, because it's very frustrating to not be able to communicate. You also don't need to be, you don't need to have very few words, or what people call nonverbal, to get an AAC or to use other communications. There's also partial users who maybe in certain settings they don't feel comfortable speaking, and so they can use them in those settings and be more comfortable. And the last intervention I'm going to talk about is psychotherapy, or cognitive behavioral therapy. So this can help with identifying emotions, and even neurotypical adults can need help with this, right? Restructuring distorted thoughts. There are programs or books you can buy, The Copying Cat and Facing Your Fears, because this is a challenge, at least in Lansing, where there might be a psychotherapist available, but they specifically do not want to see children who have autism or neurodiversity. And so there may not be someone available to provide therapy for the children. This is an area of the school part can be really challenging for families to understand, because you have this medical diagnosis of autism, and now you have to go to a school and get an educational diagnosis of autism. And the school does their own evaluation. They have their own tools, their own checklist. And then once they say, yes, it's autism, then this is from the MARS. Autism has to adversely affect their student performance in one of these areas: academic, behavioral, social, or sensory. What I typically will hear from these families is that they don't agree that they have autism that affects them academically. But as you can see, it doesn't have to be. If a child has strong academic skills, but they can't engage with the material because they can't walk in the room because of the people in the room, and they have so much anxiety about that, then they're not engaging with the material. This also can, it can confuse families because they can say, well, we didn't get the educational diagnosis of autism. Does that mean that they don't have autism? I will say in general, there are a lot of opinions about who does and who doesn't have autism. And sometimes we don't agree, not just with schools, but other professionals who do autism evaluations. But it's not uncommon for a child to have a medical diagnosis, but then not qualify for an autism diagnosis through the school. And you can get an IEP for other reasons. There's 13 other categories to get an IEP. And the most common that you might hear of is otherwise health impaired, or OHI is what we call it. So ADHD would fall under OHI. The problem with having another diagnosis and not autism is that you don't have access to that teacher consultant. And so as you can imagine, having 30 children in the classroom, it can be really challenging for if one child is having more behaviors. And so you can consult with this autism specialized teacher consultant and get help throughout the year for the teacher. But all the other things I have listed here is available through other categories or eligibility for an IEP. You can have speech, OT, PT, you can see a social worker, have visual aids, specific seating. The FBA is actually what we talked about before, the ABCs. So the school performs their own functional behavioral analysis is what it's called, to find out what is the function of their behavior. And that informs their behavior intervention plan. Because you really can't, when a child comes home from school, if they had a behavior, it's hard for you to change that from the school. They have to do it there. Then social stories, the school can issue their own AAC device for communication, and then social skills groups are available. This is actually not an inclusive list. This is from 2018 and more things have been added. But another reason I have families come back is because their needs change. And maybe the interventions we have them in right now don't serve something, or a new one pops up that is more concerning. And so learning about what the other interventions are that are evidence-based is important. I said earlier, I don't know to many of you, that most of the kids I see in my practice have autism plus something else. And that's because the risk of having some other conditions are high. ADHD is the highest at 50 to 70%, but also anxiety and depression. Sleep disorders are common. And not only that, but having a problem falling asleep or lack of sleep can increase behavioral problems. GI disorders are common. You can imagine having a restrictive diet, maybe only eating 5 things, higher risk of constipation, possible onchoparesis, but other GI conditions are higher as well. And then there's a higher risk of epilepsy. So when I see patients back, if it is 6 months or more, I'm doing evaluations to check on these mental health conditions. I ask about sleep every time, and asking about their food intake and any GI discomfort they may have. This table just shows, so first of all, before the DSM-5, which I think was 2013, you couldn't diagnose autism and ADHD together in the same person. And so this table just shows how difficult it is sometimes to distinguish ADHD and autism. And the big bars, you can see, the dark bars, are if you were diagnosed with ADHD, how much older you were going to be to get diagnosed with autism. So you were less likely to get that diagnosis in a prompt manner if you got diagnosed with ADHD earlier. And some of that is because the symptoms overlap. They just look similar in some situations. Honestly, no kid has the textbook of any condition. And so they're going to kind of have bits and pieces from each other. There's some guidelines I use, and I'm just sharing this because it's part of the evaluations I do when I see kids back. If it is a crisis and the families are looking for a medication or intervention, Society for Developmental Behavioral Pediatrics has these complex ADHD guidelines. So this is children with autism and ADHD, so that you can be most effective with what you choose, because sometimes time is of the essence. Maybe they're about to get kicked out or something from school. This is another algorithm that is useful to help with some of those ADHD medications that you might need for children with autism as well. And so I put this in here because there's a lot of buzz about Tylenol and leucovorin right now. This statement came out from Society for Developmental Behavioral Pediatrics, I think a month ago. And so this statement is available online if you want to read it further. But basically, we are not endorsing to stay away from Tylenol during pregnancy. There's no causal relationship found that Tylenol causes autism. And leucovorin, if you haven't heard about it, that's not what this talk is about. But same with leucovorin. The studies that have been conducted on leucovorin are small. They didn't really have guidelines for how much of this medicine to give and for how long. And so there's not enough data for us to recommend leucovorin. I will say I have some patients who've come to me requesting this. It's really, for me, reserved for families who have children who have few words that they use, because that's one of the biggest improvements that was seen in the studies. But again, it's not something I recommend. And it's not something that I even have guidelines to use to provide that care. So in summary, I hope you are walking away learning that the diagnosis can be challenging. It's not always as simple as it seems, but some of the delays in diagnosis and intervention are from us as gatekeepers, keeping them from the services that they need, or their interventions aren't as optimal as they could be because of how we are as providers. It's good to check in and see how therapies are going. And I ask them, like, what are your goals in speech therapy right now? Or with your therapist in another way? Because maybe it's time to take a break. These families are really doing, like, right after school, they're going to another therapy or they're going to another appointment, and then there's ABA, and it can be exhausting. And so reassessing to see what is really needed right now is important. One of the big things I do is talking to everybody. I call schools, I go to IEP meetings, I talk to psychotherapists or counselors, and it's just really important to NABA providers, BCBAs, to get this whole picture of who the child is and make sure we're all providing consistent care too. Because if we're doing one thing in school and a totally different thing in ABA, sometimes that cannot be helpful, or at home can be different. And then make sure to follow up on the school supports, because that IEP may have been serving you well a year ago, but now it's not. Now there's a learning disability or something new that's happening, or a dynamic that we need to look into. And so following up with those supports is important. That's all I have for you. Thank you.
We would love to answer any questions you have. We also have someone that's gonna help us navigate any questions that may come through online. We will run wherever we need to run. Do we have any immediate questions? I knew you would. Yes, I knew you would.
Thank you, Dr. Torres, for that wonderful talk. I really appreciate it. From the perspective of somebody who practices in primary care and sees a lot of pediatric patients, your talk spoke to the multidisciplinary aspect of care and providing the resources necessary for these children and adolescents and adults to blossom and reach their fullest potential. Coordinating with schools is something that I think can be really challenging. Can you talk to me about how you navigate that and how you can dedicate the time to make those connections?
So dedicating the time is challenging. I actually was at an IEP meeting yesterday, and it was almost 3 hours long. And so luckily with my profession and my job right now, I have some admin time and I'm able to do that. But I think a general primary care provider really wouldn't have that time. I call schools frequently, they do not call me back. And so then I have to put them on my list of I got to call them again. And so it is a lot of hounding down and it's a lot of work to do. So I would say that it's difficult.
Thank you.
One of the questions about what people have is why does there seem to be so many more cases of autism nowadays as opposed to, 30 plus years ago?
Yeah, so that is a big question, and I don't think that anyone knows the answer to that. I think some of it is, and what I hope is that we are just more aware of it. And we're able to diagnose, there's more providers who are aware of it and able to diagnose. And I think that's one of the major reasons. There's other things like the DSM-5 collapsed a couple of diagnoses, and so I think other things played a role. I also think that we missed a lot of children, decades ago who are now getting diagnosed as adults. And so, we'll see. I'm learning to like what that will be, what the answer to that will be, why it's increasing so quickly.
Recognizing that we have a number of pre-medical students, but also medical students in the audience, what is your recommendations on how you begin to have this conversation with a parent? You know, you've gone through your diagnosis steps and it's clear to you. How do you have that conversation to let a parent that perhaps is hoping beyond hope that's not gonna be what you say?
So first I start off with my test and I tell them what I observed. And I make sure that they agree with what I observed. And then I ask, was this a typical day for them? Because, they can be more social or less social, and that matters. The talk is never easy. And I think, I don't know that I even got proper training on that in my fellowship, and definitely not in my earlier training. But I think meeting the families where they're at, that this doesn't really change your child or who they are, but before they came in with this door, but it doesn't take away that this is grieving for some families. What is the prognosis? What does this mean now that we have this diagnosis? What's going to happen to my child in the future when they're an adult? And so you just have to listen to those questions and guide them. There's a lot of once children get intervention early, there's a lot of good interventions that can improve things, but you really don't know, especially when they're two, when you're diagnosing what's going to happen when they're an adult and whether they'll be able to live on their own and things like that. Those are a lot of the questions that they'll ask. So I tell them I hold a space for them. But it's hard. I've had, as a parent of a child with autism, I've had that talk and it wasn't, I don't know that there is a good way. I didn't cry, but it was a moment where, maybe that situation could have been different. And so I think that's something that we all need to work on. And I always take that feedback from my families, like how did you think that went? Or what do you take away from this?
In a similar vein, one of our viewers online is making a comment and also as a question. As a medical student, I notice residents will preface talking about a patient with ASD by saying, by the way, they are high functioning or low functioning. I would like to know how we can better step away from this more rigid language when talking about patients with ASD.
Yeah, it's something that I think the advocates in the autism community don't like. High functioning doesn't mean that they don't have a disability and severe other symptoms. And so it's something that going to that severity column or level 1, level 2, level 3 is something that people are using instead. There does sometimes in the medical world need to be enough information about the child that the next person knows what they're about to walk into when they're seeing a patient. And so, saying the level might be helpful, or saying that they use few words or things like that, or having intellectual disability along with autism, that changes the picture. But I think that high functioning and low functioning has stuck around, even with the advocates. And I don't have a good way except being a good model, using the more preferred words that they've spoken about that they want.
We have another comment online and a question as well. A viewer online says, with these new statements from the government regarding autism, how do you think this will affect the autism community, not only in terms of social and emotional impacts, but also potential insurance and systemic effects?
Yeah. It's something that we've been so stuck on, coming out with an agreement amongst other developmental pediatricians on what are we gonna say, or what are we gonna do about these parents who are requesting some of these things that we haven't even taken a step back and thought about, well, what is the autism community thinking about some of these statements? I'm in some social groups, but I haven't heard a lot of information about that either. But I can imagine, well, I know for my son, he's 15, and he said, he's very sarcastic though. I'm pretty sure he asked me if I used Tylenol and laughed about it. And, you know, so there's things that they are taking offense to that, you know, that needs to be addressed and acknowledged.
Hi, so I'm actually in the College of Education, so I'm an educator. And so I've gotten a lot of questions around parents. I'm also a BCBA, so I work with kids and I get a lot of questions from families about issues like this, and especially now with the statements from our government. And, you know, as educators, we can't, obviously I can't give medical advice. I can't tell you what, you know, I am not qualified to do that. And also, if you're working at a school, you can't make, you know, what you can't say, maybe try this or maybe try that, because the district can, you know, liable for paying for things like that. So, you know, I've always told my students, if parents ask you these things, talk to your medical provider or things like that. But I guess I wonder what a better way would be to address these things without feeling dismissive, where while also staying in my lane as I'm not a medical provider. So.
Oh, that's a good question. Because I can see that being something that's taught to stay in your lane. And with some of the statements that are coming out, it's hard to know what's real. And so if that's not in your lane, I can see that can be tricky. Yeah, this is, I agree with you. Saying talk to your medical provider is a little dismissive, but I might say, I might ask them more about it. You could maybe see where their sources are, where they're getting this information. But when it comes to whether or not this is a good thing or a bad thing to do, I think the medical provider still probably is a good choice to say and safe to say. But maybe talk to them a little bit so they don't feel so dismissive. That's a hard one, I think.
I think it's just like a really scary time for parents.
Yeah.
Because they don't know what to believe and they're desperate for answers.
Yeah,
Thank you.
yeah.
Here, and then we got another one online as well.
I promise not to monopolize questions, but I think you spoke very well about and your practices in pediatrics, but you also spoke to some adolescents and young adults. And from your perspective, when your patients are ready to graduate from the pediatric practice, where would you like to see them going for their lifelong care?
Well, so far I haven't let any of them go. So as far as like whether they're gonna still see me or not, I haven't picked that age yet. But absolutely. So, I mean, we talk about transitioning care, and I know at least at MSU, our peds department does too at a certain age, but I think they like to hold on to them a little bit too, especially if they're complex kids. But internal medicine, med peds, family medicine, any of those, it's hard to get a good list of who feels comfortable with certain kids. And I think that's one of the big, I mean, that's talks all on its own, is how do we transition these kids to other, you know, to another provider who feels comfortable and to the adult world. So, yeah.
Thank you. I mostly was selfishly making sure I shouldn't be directed to a specific subspecialist, or it should come to us as the primary care in the adult world. So
Yeah.
thank you.
Absolutely.
Okay, so there's a comment and also a question from our viewers online. The comment is, thank you for coming out to speak. This person's has a brother who is 23 and has ASD, and diagnosing and interventions have come such a long way since he was diagnosed. This person's very happy the world has advocates like you. And again, thank you for sharing your knowledge and expertise. The question from another viewer is, do you have any insight on systemic changes including potential federal insurance cuts to ABA programs.
Oh, is there something that that's come out that I don't know about? Yeah, I mean, right now, ABA is already really limited to children with autism, and it used to be for other conditions as well because of insurance. And so it does run the show of what we have access to and what we don't. But I haven't heard of that, especially with some of the newer legislation to make sure that we have access to ABA services. It was fought really hard for. And so I would be surprised, but honestly, this whole year, I have been surprised a lot about some things that have been happening. And so, yeah, if you know something, let me know.
Any other questions from here in person?
Well, first of all, thank you so much for coming. I have a quick question and then maybe a deeper question. The quick question is, I've never heard of birth order being correlated with autism. I was wondering if you could elaborate.
There's been some studies about the firstborn having a higher risk.
Okay. And also I know we have some future educators in the room. So do you have any ideas about resources for them? They probably won't go on to get a medical degree or even mostly a special education degree. They'll probably be general education teachers. Are there resources that they could look to find out a little bit more?
A little bit more about autism?
Yes, and how to best teach their kids in the classroom.
That is a good question. A lot of my resources are for families, so parents and, changes that the child is going through and helping with those. So I don't have a specific one for educators, but I can look in on that and let you know.
All right, not seeing any additional questions here. Looks like we've covered all the questions that came in online. So thank you again to Dr. Torres for coming out this evening, for bringing her expertise to the Saginaw Valley campus. And thank you to all for joining us for tonight's presentation.
Thank you.